Prasad, Consultant Radiologist in Vijaya Diagnostic Center, Hyderabad. On behalf of Vijaya Diagnostic Center, I welcome you all for today's webinar. These webinars we are having periodically as a part of interaction between clinicians and radiologists, where we come together on a common platform and discuss the topic of interest for better understanding of the topic and for mutual enhancement of each other's knowledge for better patient diagnosis, management, and care. Today's topic of discussion is MRI in pericardial diseases and cardiac masses. And to discuss the topic, we have two elite and distinguished panelists with us. Our first panelist, who is also the chief guest for the session, is Dr. Raju Kavalipati, sir, who is senior consultant cardiologist and director interventional cardiologist in Care Hospital Banjara, Hills, Hyderabad. Good evening, sir, and welcome. And our second panelist, who is also speaker for the day, is Dr. Deepak B, who is a senior radiologist in Vijaya Diagnostic Center, Himayatnagar, Hyderabad. Good evening, sir. And it is my truly privilege and honor to introduce the guest for today to the audience. And our chief guest, Dr. Raju, sir, is senior cardiologist and director interventional cardiologist in Care Hospital, Banjara Hills. Sir has done MBBS from Andhra University and MD in general medicine from Andhra Medical College in Andhra Pradesh. Sir has done DM in cardiology from AIIMS, New Delhi, and has a fellowship in cardiology from American College of Cardiology. Sir has post-DM experience of more than 26 years. And sir's previous work experience and appointments include working as senior interventional cardiologist in Yashoda Super Specialty Hospital and Apollo Hospital, Hyderabad. Sir has also worked as clinical director in Sunshine Heart Institute, Secunderabad, and as a director cath lab and interventional cardiologist in Apollo Hospital, Hyderabad. Presently, sir, as mentioned, located as senior consultant cardiologist and director interventional cardiology in Care Hospital, Banjara Hills in Hyderabad. Sir has been a past president of Cardiology Society of India in Telangana chapter and has plenty of research experience and involved as a principal investigator in national and international multi-center clinical trials. The salient ones which include the Red HF clinical trial and the Atlas ACS2 TIMI 51 trial. Sir is extremely passionate about teaching and is actively involved in teaching DNB cardiology fellows and budding interventional cardiologist. Welcome, sir. Now about introduction of our speaker, Dr. Deepak, sir. Sir is a senior consultant radiologist in Vijaya Diagnostic Center, Himayatnagar in Hyderabad. And sir has done his MBBS from St. John's Medical College, Bengaluru. And sir has done MD and DMRD from Trivandrum Medical College, Kerala. Sir has a DNB in radiology and also has international degrees in radiology, which are European Diploma in Radiology and FRCR from UK. Sir is a certified radiologist in coronary CT and cardiac MRI and has a fellowship in cardiac MRI. Sir, special areas of interest include cardiovascular radiology, breast imaging, prostate imaging, fetal imaging, and many more. Sir has delivered several talks under the aegis of IRIA, both in national as well as state conferences. And sir has authored a book chapter in temporal bone imaging. And sir has work experience of more than 14 years. And sir also keeps presenting interesting cases in in-house meetings of Vijaya Diagnostic and keeps inspiring all of us colleague radiologists. So a warm welcome to both the panelists and chief guest, sir.
Thank you, sir.
So now I request our chief guest, Dr. Raju, sir, to kindly give us clinical perspective about the patients when he sees patients with pericardial diseases in cardiac masses. What challenges, sir, you face while seeing these patients, and what are your expectations when you send these patients for imaging like cardiac imaging? Over to you, sir.
Thank you. Good evening, respected faculty and dear colleagues. At the outset, I would like to thank Dr. Prasad and his team at the Radiology Department of Vijaya Diagnostic Center for inviting me to be a part of this exciting webinar. It's a very interesting topic. It interests practicing cardiologists. Any practicing cardiologist would be interested to follow this webinar. And as a cardiologist practicing cardiology, I would also be excited, and I am very curious to listen to what Dr. Deepak is going to tell us today. But the pericardial diseases and the cardiac masses, they represent an important diagnostic challenge to a practicing cardiologist, because there are various diverse etiologies which are involved in these diseases. And there are important therapeutic implications, because once we have the diagnosis, we can properly treat. So recognizing this complexity, in fact, the guidelines, the European guidelines and the American guidelines have strongly recommended multimodality imaging approach to these conditions, pericardial diseases and cardiac masses. So the actual tool that we have as a cardiologist at hand is the, the basic echocardiogram, which is not, of course, not basic. It is a very important tool. And this echocardiogram, when it comes to these two set of conditions, like pericardial disease and also the cardiac masses, has important limitations, because there are the MRI at the this thing. It is not limited by the acoustic windows, which are the typical equilibrium of echocardiogram, and the MRI also gives a sort of reproducible, operator independent assessment of the pericardial thickness. When it comes to pericardial disease, pericardial thickness, ventricular interdependence, which we would like to see if there is a question of constrictive pericarditis versus restrictive cardiomyopathy, and also the myocardial involvement. MRI also, when it, the pericardial inflammation, the edema, all this can be assessed with the T2 weighted imaging, as well as we can look at fibrosis and active disease with MRI better than echocardiogram. The other modality is, of course, CT, which is good for calcium. When speed is the criterion, we want a quick study, or when MRI is not indicated, CT can be used. But MRI, all said and done, for cardiac masses or for pericardial disease, because of its very nature of multi-parametric tissue characterization. The tissue characterization is what gives MRI an edge over the other imaging modalities. And with that brief intro, I am very curious to listen to what the esteemed speaker is going to tell us about this. So we are all, in fact, privileged to have such a distinguished expert who will share his valuable insights and his practical experience with, I am sure he would be showing us some case examples to enlighten us. And that brief intro, I invite our speaker, Dr. Deepak, to begin his session, and I open the session to the audience. Thank you. Thank you for your attentive listening.
Thank you, sir. Thank you, Ms. for your clinical input, sir. It was really good to listen to you. Dr. Deepak, sir, over to you, sir. You can start your presentation, sir.
Yes, sir. Thank you.
Yes, sir.
I'm sharing my screen. I hope you're all able to see my screen.
Yes, sir. We are able to see, sir.
Okay, sir. And good afternoon, everybody. And thank you for the kind introduction to Dr. J. Prasad, sir. And big thank you to Dr. Narsa, sir, for the very valuable input as to what the clinicians really want to see from the cardiac MRI when dealing with pericardial pathologies and cardiac masses. So without any further delay, I would like to move to today's talk. I'd like to declare that I have no disclosures, and there has been fair usage of copyrighted material. So today's talk, I'm going to discuss certain things about cardiac MRI when it comes to pericardial pathologies. First, we're going to see the brief anatomy. Then we're going to see the techniques what we use to employ in cardiac MRI for pericardial diseases. And we're also going to see various diseases and images of various pericardial pathologies. So I'm trying to show as many images as possible. So it may be a little hurried up in the middle part of this presentation, but the idea is to share as much information as possible. Okay, so with that introduction, I would like to go ahead and show this first slide, which is we're going to discuss the pericardial anatomy first. Okay, heart has a covering that is called as a pericardium. It has two important layers, visceral, parietal, and serous together as the outer layer. Okay, the space in between is called the pericardial space. It's filled with fluid usually which enables smooth movement and gliding of the pericardium and the heart muscles. Okay, this is the cut open gross specimen showing the pericardial space. The pericardium is cut here. What the dark space, what you see is the pericardial space. Okay, this is another pictorial representation showing the pericardium stripped, and what you can see is all the several pericardial recesses. Okay, in cardiac MRI, the best sequence to evaluate pericardial thickness is the T1 dark blood spin echo sequence. Okay, what you can see, the arrows pointing this particular image is a beautiful, a very clear image of the anterior pericardium along the anterior wall of the right ventricle and the apex. So normal pericardial, there are certain values what we measure to confirm if the pericardium is normal or thickened or abnormal, which we'll see in the following slides. Okay, again, this is another image showing pericardial thickness very well demonstrated all around, and we also can see pericardial recesses in this axial section where the pointer is there. This is another section showing aortopulmonary recess. Now, for evaluation of pericardium, every cardiac MRI has to be tailored to the particular clinical question, because the test as such takes about 40 to 45 minutes. And we need to do the exact important sequences in cardiac MRI to assess the clinical situation and answer the clinical question. So these are the list of generally used imaging sequences, what we do in cardiac MRI, but not all the images are done for every patient. We do, depending on the clinical question, we change the sequences which are required for that particular patient. Now, coming to the pathology, there are various pathologies of pericardium, but we are going to go from the more common ones to the uncommon ones as we progress in this study, in this talk today. Now, pericardial cyst. This is the most common entity what we come across in various modalities like X-ray, CT, MRI. Okay, pericardial cyst is a benign condition, most common in the right cardiophrenic sulcus. Okay, it does not communicate with the pericardial cavity. It's usually homogeneous, but it can be complicated cyst as well. This is a typical appearance of the pericardial cyst in MRI. What you can see, it has got a homogeneous fluid signal, okay, and it is in the cardiophrenic sulcus, okay. Pericardial defect, on the other hand, is another entity which is very rare, where there basically absence of the pericardium, which is a congenital condition, okay. What you can see in this particular image is the absence of pericardial fat in this region. This particular region has a pericardial defect. Another patient where you see that normally in the along the anterior aspect of the heart, you see the pericardial fat. Here you don't see it very well. Again, there is a cardiac shift to the same side. So this is another case of a very, very rare pericardial defect, congenital condition. Okay. Now, when we are discussing pericardial pathologies, the most common conditions what we come across in cardiology and radiology is pericardial effusion. Okay. But cardiac MRI is not indicated to diagnose pericardial effusion in all the cases, because echocardiogram is the best modality and the first line of modality to evaluate pericardial effusion. Okay. But in some patients where the acoustic window is very poor and we are not able to evaluate properly, then MRI comes into picture. Okay. Therefore, MRI is something like a second or third line in evaluation or diagnosis of pericardial effusion. Okay. When we look at pericardial fluid, normally there is some amount of pericardial fluid in the heart, surrounding the heart. But when it becomes pathological when there is more accumulation of fluid. Okay. The good thing about cardiac MRI is it can determine what is the thickness of the fluid, and also it can determine whether it is exudative or transudative fluid. This particular image, for example, shows a simple effusion where it's a near homogeneous signal. Whereas in the following slides, I will show you complex effusions where they have different signals. For example, in this patient, there is a T1, T2 hyperintense and heterogeneous signal. Okay. In this particular patient, it's T1 hyperintense. Okay. And in this particular patient, you see a lot of septations where you can see my pointer move. These are all the septations and heterogeneity within. And another patient where you see a loculated effusion only under the surface of the heart and nowhere else you can see the effusion. Okay. So therefore, in MRI, what you can very well delineate is whether it's a exudative or a transudative effusion, or we can also say whether there is a hemorrhagic effusion or a fat within the effusion or things like that. Okay. And the next important thing, like an emergency, what we come across is a rapid accumulation of pericardial fluid causes something called as a pericardial tamponade. Okay. What it does is it increases the pericardial pressure. There will be cardiac chamber compression and there will be compromise in the filling of the diastolic filling of the heart. Therefore, the heart pumping function, that is the cardiac output, decreases. Therefore, the patient will experience hypotension, tachycardia, and cardiogenic shock. It is an emergency. So what happens in normal physiology is that the heart filling varies in inspiration and expiration. But when there is a tamponade, there is rapid decrease in both right and left heart filling, which clinically can be seen as pulsus paradoxus and Kussmaul sign. And how can we identify this in cardiac MRI? That is, we can see a diastolic collapse of the RV free wall or right atrial compression during the early systole. And there is also exaggerated respiratory variation in the flow pattern, mitral and tricuspid flow due to ventricular coupling. And also what we can see secondary signs like distension of the inferior vena cava and hepatic veins with diastolic flow reversal. All these findings can be seen very well in cardiac MRI and even echocardiogram. So important thing is we should also be able to differentiate an acute tamponade from a chronic constrictive pericarditis with effusion. This is a typical case of cardiac tamponade where you can see the arrow pointing at the collapse of the right atrial free wall and compression. This is a typical case, and you can also see the pleural and pericardial effusion in this patient. This is a case of cardiac tamponade. Next important thing when we talk about pericardial pathology is a constrictive pericarditis, right? So there are different causes for constrictive pericarditis like post-cardiac surgery. Most important in our country, tuberculosis, post-radiotherapy. What happens is pericardium is a very elastic structure. In constrictive pericarditis becomes very rigid and tough. So because of this, the heart contraction and the filling will be very much impaired. What happens is there is severe diastolic dysfunction. Consequently, there will be right heart failure. Okay. So because of all this, there is another condition which can mimic like this, which is a restrictive cardiomyopathy. So generally, we need to differentiate restrictive cardiomyopathy and constrictive pericarditis because the treatment is completely different for both these conditions. MRI helps in differentiating these two conditions, but sometimes these two conditions can also coexist. So how do you differentiate in MRI is that we first look at the pericardial thickness. Normal pericardial thickness is less than 2. Abnormal is thickened. That will be more than 4 mm. The more the pericardial thickness, the more chances that this patient will have pericardial constriction. Pericardial calcification is another thing to increase the possibility that it is actually a pericardial constriction. Pericardial calcification generally are not very well seen in cardiac MRI, but at least we can get a suspicion because calcification will cause flow signal voids in MRI. So if you see a nodular signal voids with peripheral enhancement, you can suspect that the pericardial calcifications are there, but CT is definitely very conclusive and very robust to diagnose the case of pericardial calcifications. So like I said, pericardial thickening, pericardial calcification is what we look at in cardiac MRI to confirm if there is pericarditis and pericardial constriction. But there are other also sequences what we look at. That is, what happens when there is a rigid non-compliant pericardium surrounding the heart? The intracardiac pressures between the ventricles becomes dissociated. Okay, there's something called as ventricular interdependence or ventricular coupling. Okay, this becomes altered, and the heart pressures from the respiratory pressures become isolated from the intrathoracic pressure, and there will be increased ventricular coupling and increase in cardiac filling pressures with equalization of the pressure in all 4 chambers. Normally, it is different in all 4 chambers, but it will become equal in case of constrictive pericarditis. So even in phase contrast MRI, we can see tricuspid valve inflow, which shows a restrictive filling pattern. Okay, and also in the IVC, you can figure out a similar pattern of filling. So what happens in constrictive pericarditis, like I said, is thickened pericardium. Okay, then there's an important finding called as an early diastolic septal bounce. This finding, if you see, it is very much suggestive and diagnostic of constrictive pericarditis. Okay, and also because of the, like I said, increase in the pressures and equalization of pressures, we have tubular cardiac cavities. The shape is altered; they look tubular. Okay, and you can sometimes have atrial enlargement associated with it. This is a video showing typical diastolic septal bounce. I think you can imagine. I'll show you the pointer. This is where we are looking at the interventricular septum. And this is, you can see the fluttering or bouncing appearance of the interventricular septum. If you see this finding along with this thickened, circumferentially thickened pericardium, then it is very much suggestive of constrictive pericarditis. Okay. Now, in constrictive pericarditis, like I said, there can be calcifications also. The surgeon would want to know if there is a pericardial calcification. so that they can do pericardial stripping. Okay, in this particular patient, you can see that there is a signal void in anterior aspect of the right ventricle, and this indentation of the right ventricle compressing the right ventricle. Only this part showing a hypointense signal. If you see something like this with no enhancement, you can suspect pericardial calcification and recommend that the patient should undergo plain CT chest to confirm the presence of pericardial calcification. If the patient cannot afford, you can also do a chest X-ray to confirm if there is pericardial calcification. Another important pulse sequence called as a myocardial tagging. This is also very important to confirm the presence of constrictive pericarditis. Normally, the heart layers, that is the pericardial layers, glide around the heart when there is contraction and continuous movement of the heart. So these, what this special sequences called as Dante sequences and other sequences, what they do is they create a grid pattern on the myocardium and the pericardium. So in normal cardiac cycle, what you can see is these lines sliding against each other in pericardial in myocardial tagging. But in the panel D, in the last panel, what you can see, if there is rigid and non-compliant pericardium, this sliding will not happen. So the lines which you will see will not move against each other, and they look like straight lines. You won't see the stepping or the movement of the lines in the pericardial myocardial interface. So this particular sequence, if you have, it is a very sensitive and highly specific sequence to confirm the presence of pericardial constriction in cardiac MRI. Now, there are other causes of pericardial thickening like pericardial inflammation. Simple pericardial inflammation also can cause thickening and enhancement. Okay, that can be seen as a hyperintense edematous pericardium with thickening and enhancement. Small effusions may be present, and associated myocardial inflammation also can be present. This is a typical case of a patient of post-viral pericarditis, where you can see diffuse pericardial thickening, homogeneous enhancement with no much of myocardial enhancement. So this is a patient of pericarditis. Okay, it can happen due to several causes, one of which is viral, and it can also be post-myocardial infarction and things like that. Now, we finished the pericardial thickening, pericarditis, and pericardial constrictive pericarditis. Now we're going to quickly see about pericardial masses. Okay, there are different types of masses like benign, non-neoplastic, and neoplastic. Now, first we're going to see a pericardial hematoma. This is a typical appearance of pericardial hematoma. This patient had a RTA, and you can see that there is a T1 hyperintense area, lenticular shaped area in the pericardial, causing indentation of the right atrium. This is a case of in the right clinical setting. If you see this signal in T1 hyperintense signal in a cardiac MRI, you can confirm that it is actually pericardial hematoma. And this is another patient with pericardial angiosarcoma, where you can see multiple lesions within the pericardium and fluid with multiple fluid levels. And incidentally, you can also see multiple lung nodules. It's actually, this is stage 4 disease, advanced disease of pericardial angiosarcoma. Now we've seen bit of pericardial masses. Now I'm going to this next half of the talk, I'm going to quickly talk about pericardial cardiac masses. So I'm going to give a little bit of facts about cardiac masses. The important thing we should remember is the secondaries are generally more common than primaries. In the primaries, most common is myxoma, and in the malignant ones, angiosarcoma is more common. Myxomas are more common in the left atrium, angiosarcomas are more common in the right atrium, and general other sarcomas are more common in the left atrium. Overall, left atrium is a site for most cardiac masses. Okay, so how do you approach for a case of cardiac mass in radiology? First, we look at the location, okay, whether it's endocardial, intracavity, myocardial, or epicardial. Then we see which is the structure or the chamber involved. Then we look at the morphology or a tissue. What is the tissue of the lesion, which you can very well see to a great extent in MRI, and any other distinctive imaging findings. And then we put all this together with the patient demographics and clinical information to arrive at a diagnosis. This is the approach. And like I said, there can be other lesions also which can involve the heart and look like it's actually a heart lesion. So that also should be considered and excluded. Clinically, patients with cardiac masses will have varied presentations. Some of them can be heart failure, embolic phenomena, or there are different factors which determine this: the location of the tumor, the size, the growth rate, tendency for embolization, and the degree of invasion. All this determine how the patient presents clinically to us or to the cardiologist with a cardiac mass. Like I said, based on the location, you can narrow down the differentials, whether it's intracavitary, myocardial, or pericardial, because these different locations also present differently like myocardial lesions can cause conduction abnormalities and arrhythmias. Okay, pericardial lesions can cause rapid pericardial effusions and tamponade. So different presentations can happen based on the location. Now coming to MRI, like I said, again has to tailor as to where the lesion is, what is the type of lesion, what is the size of lesion. So MRI also has to be modified for each patient based on where the mass is and all that. But this is general overview of what all sequences we do in MRI. The most important sequence in cardiac MRI is a post-contrast images. Okay, because plain MRI, most of the information we already have in echocardiogram, because that is the first line of investigation. It will detect the mass, and to further characterize, they will send it to MRI. So in MRI, in addition to plain, most important sequence what we do are the post-contrast images. There are different types of dynamic perfusion images, early gadolinium, late gadolinium, and also post-contrast T1 images. These are the kind of post-contrast images we do. In the present day scenario, we also use different other techniques like parametric imaging, T1, T2 mapping to further characterize the lesions. Now, coming to myxoma, it's one of the most common neoplasms. General female predilection, more common in the left atrium. Okay, like I said, depending on the location, it can have different, presentations. Okay, and it can also have syndromic associations like a Carney complex, which is a multiple endocrine syndromic associations. Okay, this is a typical patient of a left atrial myxoma where you can see a lesion in the left atrium and it is showing post-contrast enhancement. Another patient with a right atrial myxoma showing heterogeneous enhancement. Okay, now this is another patient where you can also see in gradient images and scene images that this lesion is actually prolapsing across the mitral valve. So MRI also helps us to see what is the dynamic information with regards to surrounding structures when there is a mass. And you can see that this is actually attached to the intra-atrial septum and prolapsing into the mitral valve. Now, this is another patient where you can see the clear central enhancement P2 heterogeneous signal within the lesion. Now, one second. Are you all able to see my screen, please?
Yes, sir. We are seeing, sir. Myxoma slide is there.
Yeah. Sorry about that interruption. Yes. Now, this is probably the important slide of today's talk. Okay, so whoever is listening, I want you to concentrate here. Most cardiologists send us to differentiate between a myxoma and a thrombus. In echo, they will see a lesion. They want to differentiate and further characterize the lesion to see whether it's actually a thrombus or a myxoma. This table clearly depicts, this is from British Journal of Radiology, it clearly depicts what are the usual differences between myxoma and thrombus. The first points are all not very specific and sensitive, but what I want to tell you is the last few points where the enhancement is what you want to see. Okay, like I said, post-contrast are the important sequences. Thrombus usually does not enhance, very uncommon for it to enhance. Highly organized thrombus can show slight peripheral enhancement, but a myxoma will definitely show heterogeneous central enhancement. Okay, and another important finding is that inversion time, what we do in look-locker sequence, is also very important to differentiate. You can see there's a significant difference in the inversion time between a myxoma and a thrombus. You can see that the myxoma has inversion time similar to that of myocardium, whereas the thrombus has a much higher nulling time compared to myxoma. So these two differentiating pointers in MRI help us to differentiate between these two areas, these two lesions. Okay, and this is another patient where you can see a non-enhancing LV thrombus very clearly depicted, and you can also see the scarring of LV myocardium post MI for a patient who already is a known patient of coronary artery disease. Now, next common ones are papillary fibroelastomas. These are actually very small lesions, usually seen in relation to the valves. Okay, so it is usually picked up in echocardiogram and sent for MRI. MRI can be challenging sometimes because most of the lesions are less than 1 centimeter. Therefore, we need to focus particularly around the valves or the area of interest to further characterize these lesions because they are usually very small and along the endocardial or surface of the valves. Okay, so this is actually a typical appearance of a small lesion you can see here. If you don't pay attention, radiologists also can miss these lesions. Therefore, you need to see in volume sequences or thin sections to correctly delineate the mass and see what is the further characterization within the mass. Now, other relatively common in younger age group are rhabdomyomas. Okay, so this can be part of isolated sporadic lesions, or they can be associated with tuberous sclerosis. Okay, but basically they are benign conditions. Okay, they're usually asymptomatic. They can be picked up incidentally in echocardiogram. Most of the sometimes they regress, and surgery may not be required in rhabdomyomas. This is a cut section pathology specimen of a rhabdomyoma, which is more common in the ventricles. Now, in echocardiogram, they'll be seen as solid hyperechoic masses, or diffuse rhabdomyomatous also can be seen where there is diffuse myocardial thickening. Towards the end of this slide, I will also show a very interesting case which we came across to differentiate between mass like HCM and a mass in the myocardium, because that signal also can resemble a signal like a rhabdomyoma. That is the reason I brought that point up right now. Okay, again, like I said, MRI allows better tissue characterization and delineation between lesions to differentiate different type of lesions. Again, fibromas are another type of lesions which are again can be syndromic associations when they are usually present in the myocardium. Therefore, they can present with arrhythmias and conduction abnormalities, usually at a younger age group. Okay, and they usually always single, and they can calcify. That is another pointer which helps us to say that it could be a fibroma. This is another patient where you can see that it's a fibroma where there is a severe thickening of the right ventricular free wall. Okay, you can see that it's slightly hyperintense compared to the rest of the myocardium. Okay, is another patient. You can see similar involvement of the left ventricular myocardium. Now, hemangiomas are relatively uncommon in the heart muscle, but we do see. Most importantly, what you have to know is that in MRI they can be very intensely enhancing and T2 hyperintense. Sometimes, if you're lucky, we can also see the blood supply of the lesion from the epicardial coronaries in coronary angiogram images. Okay, lipomas. These are also again very less likely what we see in myocardium. Again, MRI is excellent in diagnosing lipomas because it can very clearly pick up the fat signal within the lesion. They can be single or multiple. Okay, and this is a typical patient of a lipoma where you can see a typical fat signal. You can see that it is paralleling. The signal is paralleling the chest wall fat as well. So that's another benchmark to compare with the rest of the body fat to see if it has actually a fat signal. Okay. Now, paragangliomas are again very rare in the heart. Okay, they're more common in the atria. Around middle age is more common, and importantly, MRI is not the first line to diagnose such a lesion. Okay, generally we do MIBG and nuclear scans to localize the lesion, and then maybe do MRI or echocardiogram to further characterize the paragangliomas. Okay. But in CT, what we can remember is that they can show marked enhancement. All paragangliomas in anywhere in the body show marked enhancement. Like in this patient where you can see it's very much T2 hyperintense and it is seen in the centered in the interatrial septum. Now, teratomas are generally more seen in the younger age group. Okay, they are complex heterogeneous masses. They can be aggressive. They can be seen in mediastinum, secondarily involve the heart structures, or can also be seen sometimes in the heart lesions. Now, coming to quickly about malignant lesions of the heart, sarcomas, like I said, are more common. In that, angiosarcomas are more common. Other ones are malignant fibrous histiocytoma, osteosarcoma, and leiomyosarcoma, more common in the middle-aged elderly. Okay, they are aggressive, they can metastasize, and they have a poor prognosis. Like I said, angiosarcomas, we already saw one picture. They can cause hemorrhagic effusion. They will be multilobular, aggressive appearance involving the myocardium and probably extra cardiac spread as well. This is a typical appearance of a ill-defined infiltrative sarcoma. Sometimes we do see lesions like this, but we can also get lymphoma which can look like this. Again, lymphoma will be a typical homogeneous lesions which show homogeneous enhancement. Generally, it is in an elderly age group with a male preponderance, and generally more common cardiac involvement are B-cell lymphomas, which are generally very rare. But when it's involved, it is more common in the right side of the heart. Okay, and more than one chamber, contiguous chamber involvement can be there. pericardial involvement and effusion can be there. This is a proven patient of cardiac lymphoma where you can see multiple chamber involvement and pericardial involvement as well. This is actually a CT image. Again, like I said, whenever dealing with lesions of the heart, we should always exclude a metastasis. In this, if you only look at the heart image, it looks like there is some lesion in the right atrium, but actually there is a metastatic lesion in the IVC, which is projecting into the right atrium in this particular patient. There's an interesting patient which came across, my colleague came across. We can see multiple cardiac masses in the right atrium and right ventricle, which are showing enhancement. There is also enlarged subcarinal lymph node in this patient. This is actually a patient of pericardial and cardiac tuberculosis, okay, which is masquerading as a cardiac mass. So in Indian scenario, we should always have tuberculosis in the back of mind in all the diagnosis of cardiac masses, and make sure that we pay attention to tuberculosis and exclude it before we commit on any other aggressive masses. Now, quickly, I'm going to summarize how we're going to approach a mass based on the location. Like if it is a valvular lesion, we know it could be a fibroelastoma or vegetations, so and so. So based on the location, we can narrow down the differentials as we can see very well in this particular slide. Like I said, if it's a small lesion, it is likely to be either a fibroelastoma or vegetations or a small thrombi or myxoma. This is again a differentiating table between rhabdomyoma and fibroma. You can see that the calcifications are more common in fibroma. Rhabdoma tends to be more multifocal. Cystic changes are more common in fibroma, and the T2 signal helps us to differentiate between rhabdomyoma and fibroma. Another condition is a lipomatous hypertrophy of the interatrial septum. Again, this table help us to differentiate between lipoma and lipomatics hypertrophy of the interatrial septum. This is a patient, a typical appearance of a fat signal within the interatrial septum, which is thickened, which has a wedge shaped, and is a typical appearance of a lipomatous hypertrophy, which is a benign condition. This is one patient we came across in Vijaya Diagnostics. They saw a focal thickening of the interventricular septum basal region, and they wanted to differentiate between a mass or it's like a mass like a hypertrophic cardiomyopathy. You can see that this is a T1 weighted parametric imaging, T1 mapping, where you can see the T1 values of this particular lesion where the thickened interventricular septum is there are significantly increased compared to the rest of the LV myocardium. And this area is also showing enhancement in the rest perfusion imaging and in delayed post-contrast imaging, whereas the rest of the myocardium is absolutely normal looking. So with this, we can conclude that is actually a focal lesion, a neoplastic lesion, rather than a mass-like hypertrophic cardiomyopathy. Because in another slide, we can see this patient where you can see that it's actually a focal thickening of the anterior left ventricular wall. You can see that this is not focused, this is more diffuse than the previous patient what we have seen. And what we can also see that we did a T1 mapping again for this patient. We saw that there's a lot of fibrosis and T1 increased values within this lesion, but it is not showing the typical mass-like enhancement. It is showing mid-myocardial patchy enhancement, which is very typical of hypertrophic cardiomyopathy. Okay, the fibrosis of hypertrophic cardiomyopathy will look, this pattern of enhancement will be seen. Therefore, we concluded that this is actually a mass-like hypertrophic cardiomyopathy rather than a neoplasm. So, like I said, this way MRI helps us to differentiate between mass-like HCM and a mass actually masquerading as a mass-like hypertrophic cardiomyopathy. So, quickly to summarize, how do you approach the lesions based on the location, whether it's endocardial, myocardial, epicardial, or pericardial? Which is the chamber or structure involved? We look at the morphology of the lesion. We look at any distinctive imaging findings to conclude what type of differential or most possible plausible diagnosis we can offer to the clinician. So I think MRI is really a one-stop destination to and a modality to really characterize the lesion and give the most possible diagnosis. Also, like I said, we need to correlate with the patient demographics to arrive at a most plausible diagnosis or what type of lesion it could be. And like I said, extra cardiac conditions or metastasis also has to be excluded while we are evaluating cardiac lesions. So this concludes the talk, and I thank you all for your patient listening. I will therefore stop sharing my slides and presentation. And over to moderator Dr. J. Prasad sir, and thank you all for your patient listening.
Thank you, sir. Thank you, Dr. Deepak. It was an excellent presentation and very nice images. And I'm sure we all will go through the recorded presentation, which will be available in the social media platforms. It was really great to see the presentation, sir. All important points were covered and all important masses were covered. Thank you, sir. Thank you very much. Now, I would like to request our Dr. Narsa sir to kindly give comments and any clarification, or you want to add up anything, sir?
Yeah, thank you, Dr. Deepak, for an excellent and insightful presentation. Your talk very clearly highlighted the importance of MRI, and especially in very specialized disease conditions like pericardial disease and cardiac masses, where other investigative tools like CT and echocardiogram fail to give this much information. Of course, this is all complementary. All these tools should be viewed like complementary to each other. Sometimes what we can't make out on an MRI, sometimes we make out on a TEE. So it is not that MRI is the one stop. I don't totally agree with that statement, but when we are dealing with very small vegetations or some valve vegetation, of course he didn't cover about the vegetations, which is another thing which we as cardiologists would be interested in. The valve has a mass lesion. Is it a vegetation, or is it a fibroelastoma or something else, a thrombus? We would like to know all these things. Sometimes what we find is that the TEE gives us better information, the transesophageal echo.
Yes.
I think his talk covered most of the things in a very lucid fashion, and I thoroughly enjoyed the case examples that he has shown are also very interesting. This would be available again on the I came to know that it is again available on the YouTube and all that. I'll go through again, follow what Dr. Deepak is trying to convey to us. It's an excellent talk, and I thoroughly enjoyed the 40 minutes of your talk. Thank you, Dr. Deepak. Thank you, Dr.
Thank you, sir. Thank you, sir. Thank you, sir. So I think there are no more questions on the social media. So Deepak sir, one question for you, sir. When we have a deranged renal function, so can we still go ahead and get a good amount of information about the lesions in cardiac MRI for patients?
Yes, sir. So certainly we can get more information than what we can expect in echocardiogram. Like I said, tissue characterization, if it's a lipoma, we can clearly say that it's a lipoma. We don't even need contrast for that. So even if there is no renal dysfunction, even with a plain study, we can come to the diagnosis. But to differentiate myxoma and thrombus, sometimes most of the time we need a contrast study. But like I said, the recent advances like parametric imaging, T1 and T2 imaging will throw some more light to further at least say which is more likely, even if we cannot conclude, but we can actually do this parametric imaging and see what is more likely, whether it is likely to be a thrombus or a myxoma. So that way, to a certain extent, we can definitely throw more light into the clinical situation, even if there is renal dysfunction and we are not able to give IV contrast. With these newer techniques, we can do some justice to the situation.
Yes, sir. Got it. And Dr. Narsa, sir, I have one small query, sir. Many times we get these 2D reports saying that there is small nodule in the atrioventricular valves, and they want to evaluate ahead with the cardiac MRI. So, from our side in the literature, there is no definite size criteria mentioned where the cardiac MRI is more sensitive to characterize the nodule. So, in your clinical experience, any cutoff value for the nodular lesions of the valves where you feel like further imaging by cardiac MRI can be helpful, or you directly go for a TEE in those cases?
Yeah, see, ideal for very small lesions, MRI I don't think would be a very good tool to look at these nodules. The better test would be a TEE. I mean, if I'm surprised if some cardiologist is asking for very small nodule and a valve, if he's asking for an MRI to further illustrate what it is, I think it's probably not correct. We should be doing a TEE rather than an MRI for very small lesions. In general, if it is less than 1 centimeter, I don't think MRI, correct me if I'm wrong, Dr. Deepak and you, both you can correct me. In general, if it is less than 1 centimeter, the chance of picking it up on MRI would be very low. Is that correct? Is that statement correct?
Sir, absolutely, sir. I totally agree with what you're saying. Even Dr. J. Prasad sir also, I think, feels the same. Because the smaller the lesion, the more difficult it becomes to see in MRI, especially if it is close to the valves because of the inherent constant movement of the valves. It becomes very blurred for small lesions. So if you ask me personally, I totally agree with what you're saying, that if a small lesion is less than 1 centimeter, it is better, though it is invasive, it is better to go with the transesophageal echo because it gives excellent sensitivity and specificity compared to MRI for small lesions. For bigger lesions, of course, we can definitely do MRI. I agree, sir.
Got it, sir. Thank you, sir. Thank you much, sir. Thank you, sir. So, I think there are no more questions in the chat box, sir. So, with your due permission, sir, our chief guest, Dr. Narsa, sir, and Dr. Deepak, sir, we would like to wind up. And on behalf of Vijaya Diagnostic, I thank both the guests for taking your precious time and joining and gracing the webinar, sir. Thank you very much, sir. Thank you very much. I would like to thank Vijaya Diagnostic Center Management for allowing us to conduct the webinar, and also like to thank the digital communication team for conducting the webinar smoothly. Thank you very much, sir. Thank you,
sir.
one and all.
Thank you, everyone. Thank you, sir.
Thank you.
Thank you, sir.